Introduction background. Glucagon-like peptide 1 exerts its main effect by stimulating glucose-dependent insulin release from the pancreas and functions as an intergastrone and impacts gastric motility by affecting vagal afferents, which lead to a slowing of gastric motility. GLP-1 agonists are pharmacologically formulated medications that bind to the GLP-1 receptor, causing this biological response. Short and long-acting formulations of GLP-1 agonists are available, both slowing gastric motility. Short-acting GLP-1 agonists consist of exenatide and lisenzatide and have a duration of action of only a few hours. Long-acting agonists include liraglutide, exenatide, abiliglutide, deglutide, tirzepatide, and semaglutide. Historically, this class of medication was exclusively prescribed for the management of diabetes. However, in more recent times, the United States Food and Drug Administration has approved this medication for chronic weight management, leading to a widespread trend in its prescription. As the usage becomes more prevalent, healthcare practitioners have acknowledged an elevated risk of adverse events such as delayed gastric emptying, nausea, and vomiting during general anesthesia. The existing nothing by mouth guidelines advise a minimum fasting duration before anesthesia administration, 2 hours post clear liquids, 6 hours after consuming dairy or a light meal, and then 8 hours or more following a fatty meal. The systematic review was designed to assess the necessity for adjustments to the current NPO guidelines specifically tailored for patients taking GLP-1 agonists. Relevant literature. The diffusion of innovation theory focuses on the adoption of a new clinical behavior or practice by a clinician in the healthcare setting as a consequence of factors such as research. Presently, the DIT identifies 5 fundamental characteristics as precursors to adoption. These include the relative advantages, complexity, compatibility, observability, and triability. The PICO we developed aim to identify recommended modifications to the perioperative NPO fasting guidelines for patients taking GLP-1 agonists scheduled for general anesthesia. Examining each essential characteristic of DIT, the modification of the NPO guidelines suggests a proven advantage through research, demonstrating a decrease in adverse events with extended NPO times. Compatibility and observability of the diffusion of this change will continue to grow as practitioners continue to study and report the positive relationships between the alterations of NPO times and the decrease in adverse events related to GLP-1 agonists and adverse events. Problem statement objective. GLP-1 agonists are often taken for either diabetes management or weight loss. This class of medication is associated with many adverse gastrointestinal side effects, and there are no specific preoperative guidelines on discontinuing specific therapy. Therefore, the purpose of this systematic review is to assess and evaluate patients taking GLP-1 agonists scheduled to undergo anesthesia and what are the recommended modifications to the standard NPO fasting guidelines to ensure optimal perioperative safety for the patients. Criteria for studies and review. Participants included specific inclusion criteria for this review were patients taking GLP-1 agonists, treatment for weight loss, or diabetic management. Only patients undergoing anesthesia were included. The phenomenon of interest was the preoperative fasting hours of patients taking GLP-1 agonists. Studies that did not study the fasting hours of patients taking GLP-1 agonists were excluded from the study. And the studies were eligible for inclusion if the articles included NPO guidelines, ASA guidelines, surgical fasting protocols, and preoperative fasting guidelines. Studies that did not have information on patients taking GLP-1 agonists and NPO guidelines were excluded. Types of outcomes measures. The primary interest of this review was to assess and evaluate patients taking GLP-1 agonists who were scheduled to undergo anesthesia and what are the recommended modifications to the standard NPO fasting guidelines to ensure optimal perioperative safety for the patients. Studies that did not discuss NPO times, aspiration, pneumonia, or perioperative outcomes related to GLP-1 agonists were excluded. Types of studies. All methodologies were considered during the initiation of the literature research. Studies that were published before September 2008 were excluded.
Our PICO question is in patients taking glucagon-like peptide 1 agonist scheduled to undergo anesthesia, what are the recommended modifications to the standard NPO fasting guidelines to ensure optimal perioperative safety? For the patient population, we identified in our search strategy patients taking GLP-1 agonists and then those undergoing anesthesia. Our keywords were the various brand names as well as generic names of the GLP-1 therapies. For intervention, we searched for extended fasting, and our key phrases were perioperative NPO times, perioperative discontinuation of Ozempic, fasting hours, solid fluid, clear liquids, and food abstinence. For comparison, we did NPO guidelines and used keywords as perioperative surgical NPO guidelines, ASA NPO guidelines, surgical fasting protocols, and perioperative fasting guidelines. For outcome, we looked for perioperative outcomes, and in this we listed several possible outcomes from general anesthesia, such as aspiration pneumonia, perioperative aspiration pneumonia, Mendelssohn syndrome, post-induction aspiration, aspiration regurgitation, aspiration pneumonitis. Here in our flow sheet, you can follow along as we identified the articles to include in our study. At the end, we ended up with 7 articles total.
Literature selection. The inclusion and exclusion process followed the preferred reporting items for systematic reviews and meta-analysis. Guidelines. 10 articles were reviewed for inclusion and exclusion. 2 studies were excluded for having a title and abstract that did not meet the research question. Full text or versions of the remaining 8 articles were screened for eligibility. 2 doctoral nurse anesthesia students used the Joanna Briggs Institute JBI checklist to critically appraise the articles. 1 article did not pass the JBI checklist because it did not meet the criteria for the research question. Both students discussed and agreed upon the appraisals to determine the qualifying studies for the final systematic review. A total of 7 full-text articles were found eligible for inclusion in the final systematic review. To illustrate and organize the selection process, a prisma diagram was completed.
A total of 7 studies were included in the systematic review. The types of studies included 4 case studies, a matched pair case control study, a prospective observational study, and a single center retrospective electronic chart review. The participants included males and females who were greater than 18 years or older. 3 studies were performed in the US, Canada, and Japan. The studies were conducted from February 2023 to August 2023. The 2 themes that emerged from the research were guidelines for perioperative management of GLP-1 agonists and GLP-1 agonists versus not taking GLP-1 agonists and gastric residue. So for the theme of guidelines for perioperative management of GLP-1 agonists, we'll kind of run through a few of the studies. Vagina published a single case study comparing the presence of gastric residue in a patient prescribed GLP-1 agonist when following standard NPO times versus modified NPO time. The subject was a 31-year-old female taking semaglutide subcutaneous weekly who was scheduled to undergo an EGD. For the first EGD, their solid meal was last consumed 10 hours prior to induction, and upon placing the EGD probe, they showed a large amount of food in the gastric body. 1 month later, they had the same subject return, and they held the medication for semaglutide for 7 days, as well as did a clear liquid diet for 36 hours. Upon this second EGD, they found that there was no food present in the stomach. So from this, the authors suggested implementing extended fasting periods, prescribing a prokinetic medication, using preoperative ultrasound assessment of gastric content, or halting semaglutide therapy prior to procedure to mitigate the risk of perioperative pulmonary aspiration. Glock and Murphy published a case study as well about the unanticipated regurgitation and aspiration of under anesthesia, along with strategies to mitigate the risk. Their subject was a 48-year-old female taking semaglutide therapy to undergo a breast lumpectomy. Her last dose of semaglutide was 2 days prior, and the patient's last solid meal was 20 hours prior to induction. In this scenario, the authors believe the aspiration was due to the semaglutide therapy, and it should have ideally been held for 4 weeks prior to any anesthesia. Weber also published a case study, and their subject was a 59-year-old female undergoing general anesthesia for a hysterectomy with no history of diabetes. The patient was reported to have fasted appropriately, but did aspirate after induction. The authors suggested potential solutions such as prolonging fasting times with a liquid diet prior to surgery, screening with POCUS, gastric ultrasound, a rapid sequence induction, or discontinuing the medication prior to procedure. Wilson's study looked at a 55-year-old female with hypertension, hyperlipidemia, and diabetes managed on metformin, taking once weekly dulaglutide or Trulicity. She did aspirate after induction of general anesthesia, but in this surgery they did not know if the gastroparesis was due to her underlying diabetes or if this was due to the GLP-1 therapy. In the theme GLP-1 agonists versus not taking GLP-1 agonists and gastric residue, all 3 studies evaluated the association between treatment with GLP-1 agonists versus no treatment with GLP-1 agonists on gastric residue in EGD. In summation, the literature supports the risk of perioperative complications due to increased gastric residue with patients taking GLP-1 agonists. The studies differed in the fasting hours and used 2 methods to identify gastric contents. The subjects in Kabori had been fasting for over 12 hours, meanwhile the participants in Sherwin's fasted for at least 10. The subjects in Silveria fasted for 2 hours for clear fluids and 8 hours for solids. In the prospective observational study by Sherwin, the authors took it a step further by investigating NPO time specifically related to solid intake versus clear liquid intake. Their findings indicated elevated gastric content in patients taking GLP-1 agonist therapy compared to those not, regardless of whether the intake was solid or clear liquid. Sherwin and Kabori identified an increased risk for patients on GLP-1 agonist therapy, however, they did not provide recommendations for modifications. In the single-center retrospective electronic chart review published by Silveira, the authors did suggest discontinuing semaglutide for 10 to 14 days prior to procedures requiring general anesthesia. All research indicates increased risk for perioperative complications. Identifying exact modifications to current guidelines requires further research. Applying the grading scale established by the United States Prevention Service Task Force, this evidence is assigned a grade C with a moderate level of certainty. The author's conclusions: the literature indicates a requirement for modifications to current NPO guidelines. There is insufficient robust evidence to specify the optimal changes needed to minimize the risk of adverse events associated with increased gastric contents in patients taking GLP-1 agonists undergoing anesthesia. Additional research is warranted to establish definitive modifications to policies and guidelines. As with any study, there are strengths, limitations, and challenges. Vagina mentions that their 31-year patient with underlying diabetes, the gastric residue could have been due to the diabetes rather than the GLP-1 therapy. Gluck and Murphy recognize that they may have had a mistaken association of the gastric residue. Weber did not identify any study limitations. Kabori did recognize that their strengths included a large sample size, and their limitations were the potential interference of other medications on effect on gastric motility. Sherwin identified a limitation of a smaller sample size, as well as Silveira and Wilson. And due to the early stage of this subject, there are no randomized clinical trials identified in the literature at this time. Authors' recommendations. A major theme that emerged from the research was the overwhelming need for further studies. Each study highlighted an elevated risk of increased gastric residue in individuals taking GLP-1s. The ASA does recommend discontinuing GLP-1 agonists on the day of the procedure for daily dosing and discontinuing weekly dosing of GLP-1s a week prior to surgery. However, they also do acknowledge that there is no evidence to determine the optimal duration for holding these medications. The current absence of evidence to support the modifications to MPO guidelines prevents a definitive answer to the PICO question at this time. A suggestion would be to conduct a further literature review as additional research unfolds. Implications for practice. The existing literature indicates a requirement for modifications to current guidelines. However, there is insufficient robust evidence to specify the optimal changes needed to minimize the risk of adverse events associated with increased gastric contents in patients taking GLP-1s undergoing anesthesia. As you can see listed right here, the several the studies that we have all have different recommendations, and given these discrepancies, it is evident that additional research is warranted to establish definitive modifications to the policy and guidelines. Many of the studies identified in the literature review were retrospective in nature. It would be beneficial for future studies to be prospective. Prospective studies would allow for more controlled data collection, ensuring high quality and standardized information. Additionally, larger sample sizes would be beneficial to allow for more robust study results. Finally, there's a recognized heightened risk of gastric residue in patients using GLP-1 agonists. It would be advantageous to explore specific adjustments to the existing NPO guidelines to pinpoint the most effective modifications.